Welcome to today's conference with ethnic media titled In the Grip of a Triple Crisis, How Does America Move Forward? I'm Sandy Close, Director of Ethnic Media Services. Today's conference is the 10th in a weekly series we began on March 27th to track the impact of the COVID-19 pandemic. Each week, we have been honored to present speakers who help us journalists report on these momentous times. Today, we were unable to schedule a spokesperson who could offer perspective from Native America, and that's our loss. We plan to address that in the coming weeks. On behalf of Ethnic Media Services, I want to extend a special thanks to Blue Shield of California Foundation and the California Healthcare Foundation for their support of this initiative, and to veteran ethnic media reporters Pilar Marrero and Sumita Sarabji for coordinating these conferences. As of next week, we will ask media reporters and other invitees to pre-register and receive a password to access the conference. This is a step we need to take to safeguard our conference calls from getting hacked. For today, we did not require pre-registration. So if we do get an unwelcome Zoom bomb, we ask your patience and we will close down that entry and unfortunately have to block future participation.
This is a very momentous week in the United States. The COVID pandemic has not gone away. Some jobs have come back, but the unemployment rate and the pace of layoffs remain at depression-like levels, despite the recent improvement, and the impact is still disproportionately on people of color. And now the persistent racism and racial injustice has brought us to a moment of massive protest and an outcry. We have invited leaders and advocates in the civil rights and racial justice field to share their recommendations. As usual, we will start with Dr. Tung Nguyen for an update on the pandemic, and he will also speak about the health disparities that continue to hit people of color harder than anyone else. Dr. Nguyen, please go ahead, take the floor.
Thank you, Pilar. Hi, everybody. I'm here first to give you a quick update and then say a few words about the health implications of recent events. As of yesterday, I think, there are over 6.5 million people diagnosed with COVID-19 and nearly 378,000 deaths worldwide. In the United States, there are now over 1.8 million infections and more than 107,000 deaths. The CDC is reporting forecasts that we will have between 118,000 to 143,000 deaths by June 27th. And as far as the number of cases in particular states, they are rising in 17 states, including California, Texas, Florida, and North Carolina. There's a recent study that showed that emergency room visits actually declined by 42% compared to the same period last year, indicating that while they may be going for COVID-related problems, people may be avoiding going to the emergency room for other possibly severe medical problems, which reminds us that the morbidity and mortality associated with COVID-19 includes the worsening of other health problems due to competing priorities. Given the context of the events happening last week around the police violence against Black people and the resulting protests, we would expect to see in the near future a rise in number of infections in some areas. Some of us working in the health field are contending that the use of tear gas, which makes people cough and have teary eyes, will likely increase the risk of COVID-19 transmission. And if we are having a concern about the spreading of the pandemic due to the protests, we would recommend that the police do not use tear gas. On the prevention front, there is a survey that found that men were less likely than women to wear masks. which is not that surprising because in general, men don't do as well as women with healthy behaviors. But the difference does not exist in counties that have mandatory mask wearing, which is a support of that policy. A review of 172 studies with 25,000 or more patients found that, number one, face masks were effective in preventing infection, with N95 masks more effective than surgical masks, implying that people at high risk, like healthcare workers, should be using the N95s. And then at a distance of 1 meter or about 3 feet, prevented some infections with more protection over longer distances. In a more genetic study, a European study looked at the association of genes with COVID-19 disease severity. They found 2 genetic loci, including the one that actually determines a very common thing that we know, which is blood type. Blood type A were, for some reason, more likely to have more severe COVID outcomes. On the testing front, Dr. Redfield, the director of the CDC, admitted in Congress this week that data collection has been insufficient to address disparities. And the Department of Health and Human Services has stated that testing data submitted to the CDC will have to have race, ethnicity, age, and zip code information. On the treatment and vaccine front, the large multinational study that I quoted, I think last week or the week before, showing that hydroxychloroquine has caused harm, has been retracted. But there remains other studies showing harm and none yet so far showing a benefit from hydroxychloroquine. A study looking at taking hydroxychloroquine right after exposure to COVID-19, this is the kind of thing that I think Donald Trump did, found that it did not help to prevent infection, though. And then finally, I'll end a scientific update with a bit of good news. There are now 17 vaccines in human trials. The earliest one, the Moderna vaccine, is expected to go into phase 3 testing, basically the last step before making a decision whether or not it works, by July, when they plan to test in about 30,000 people. Sandy asked me to make some comments on health disparities as they relate to the pandemic, the economic downturn, and the civic outrage. Those of us working in health disparities have known for several decades that the main underlying causes of health disparities are the social determinants of health, and they include poverty, education, the environment, and healthcare access. Racism is often thought to be one of these determinants as well, because we know that chronic exposure to racism causes the body to change adversely through the release of stress hormones and neurotransmitters. We also know that acute exposure to racism can lead to death, as in the case of the recent killings of George Floyd, Breonna Taylor, Ahmaud Arbery, and others. From a health disparities perspective, the George Floyd shooting was an acute exposure to racism, with 4 police officers serving as the vectors that delivered the disease of racism and its ultimate health outcome, death. But racism also underlies the other social determinants of health, because racial ethnic minorities, particularly Black Americans, also suffer more from income inequalities, educational disparities, and environmental degradation. So from the point of view of the health disparities researcher, there is not much new about COVID-19 pandemic other than the novel coronavirus. The pandemic has had 2 major effects, though, besides the obvious health and economic ones. In my view, it's severely stressed all of our dysfunctional systems, the health, economic, legal, and political, to their limits and broke them. We can no longer pretend that they are good enough. They were never good enough except for those of us who enjoy privilege. That is the second major effect. It ripped down the so-called color blinds from our eyes so we can no longer pretend that we all benefit or suffer the same. It has been distressing for us to find out that 1 out of 2,000 Black Americans have died in the COVID pandemic, and that their mortality rate is 2 to 3 times more than white people. But again, this is not surprising to disparities researchers. Before all of this, there has been data that show that even Black people in high socioeconomic level have much shorter life expectancy than middle-class whites. The fact is that most of us who are not directly affected hear these reports and then move on. Nonetheless, the data from the pandemic has been revealing and important. And this is one reason why I am constantly putting out the need for more and accurate data. And as has been for decades, the data in this pandemic has been insufficient and often inaccurate. One thing I've learned from 20 years of health disparities research is that whenever the data is not there, it's because somebody powerful doesn't care. And when it is not accurate, it is because somebody powerful wants it that way. One very important example, Congress has for decades prevented federal funding of gun violence and gun control research. So it's no accident that we are always saying we need more and better data for racial and ethnic minorities because there are not enough minorities in powerful places. And in the absence of data, America can pretend that there are not so many health disparities. Just as in the absence of cameras, policemen and law and order people can claim that crimes had been committed and murders were justified. But I'm not a typical academic researcher who only asks for more data. I view those who ask for data on disparities who do not intervene as being complicit in the racist system. We know that even before a single data point was collected, there would be significant health disparities in the pandemic. And we must assume that in the absence of additional data, that there are disparities, not that we have to prove they exist. The people who insist on seeing data showing disparities before acting are likely to be the same people who, when such data are collected, will deny their existence or not take them into account in their policies. And so it goes with the economic downturn. We knew before any data came that the small business stimulation package would not go equally to our communities. We know that low-wage workers will be the first to lose their jobs. Many of them are minorities. And I haven't even seen the labor statistics from today, but I can tell you that without seeing it, I can tell you that minorities will have higher unemployment rates. And so it is too with police brutality. At my university, it seems like every single Black man, from the janitor to the tenured professor, has a police encounter story. To me, that's data. There have been enough police shootings of Black men in our time to have the statistic that 1 out of 1,000 Black men can be expected to be shot by the police in their lifetime. We don't need more data. I'll finish by saying, why would a physician and public health researcher concern himself with unemployment and police violence? It is for the same reason that we concern ourselves with climate change, homelessness, food insecurity, educational disparities, income inequalities, and racism. Because the final outcome is a sick or dead person and sick and dying communities. Because racism is a disease and police brutality is a disease vector. And the job of a physician and a public health interventionist are the same. Control the vectors and eradicate the disease. Every week, I want to bring you some good news about what's happening with the pandemic. And I am, like you, impatient to see something work. But what is going to cure the disease of racism and control the vectors of police brutality? I tweeted once that perhaps we should practice social distancing between the racists and the rest of us. The protests of the last 2 weeks are beginning to look like an intervention that may work on the disease of racism. Let's call protesting the new social distancing intervention of the racist epidemic. Thank you.